The security footage shows it clearly. A man in green scrubs, no badge, no name tag, walking calmly through a corridor filled with smoke, screaming, and blood. He doesn't run. He doesn't shout. He moves like someone who has done this before. Many times. In places far worse than this. The hospital is collapsing around him, not from an earthquake, not from a bomb, but from within. A mass casualty event. 57 patients. One night. Zero coordination. The charge nurse is gone. The attending physician has locked himself in a supply room. Administration is on the phone with lawyers. And this man, this suspended nurse, this nobody, this person they threw out of the building 3 days ago with a written warning and a security escort is the only one moving toward the chaos instead of away from it. At 11:47 p.m., the hospital director's phone rings. "Sir, we have a situation. Who's running trauma coordination?" Silence. Then, quietly, "The suspended one, sir. The nurse. He just took over." The director pulls up the security feed. He watches the man in green scrubs stand at the center of the corridor, calm, still, eyes scanning, and begin issuing orders that nobody questions. The director doesn't speak for a long time. He doesn't know it yet, but that man has coordinated mass casualty events on 4 continents. He was never just a nurse. The morning shift at St. Aurelius General Hospital began the way it always did. Noise. Trolleys rolling across cracked linoleum. Monitors beeping in overlapping rhythms. Nurses calling across stations. Physicians walking fast with their eyes down. Orderlies moving between rooms with the practiced invisibility of people who had learned that being noticed meant being given more work. It was 6:47 a.m. Trauma Unit C was already running behind. In the middle of all of it, unhurried, unnoticed, Kareem Yusuf moved through the corridor with a plastic tray of morning medications, checking each label against his patient list with the careful attention of someone who understood that small mistakes in this building had permanent consequences. He was not tall in a way that made people look twice. He was not loud. He did not carry himself with the particular energy of ambition that most staff in their mid-30s wore like a second uniform. He simply moved steady, quiet, present the way certain objects in a room are always there but rarely examined. He had worked Trauma Unit C for 11 months. In that time, he had received no formal commendations. He had attended no department social events. He had not joined the WhatsApp group that the nursing staff used to share complaints about management and photographs of their lunches. He kept his locker clean. He submitted his reports on time. He never asked to leave early. His supervisor, senior charge nurse Dahlia Osman, had written in his last quarterly review, technically proficient, maintains appropriate patient ratios. Communication style is minimal but effective. Under additional comments, she had written, hard to read. She meant it as a neutral observation. Later, she would understand it differently. What the quarterly review did not capture, what no review at St. Aurelius had ever captured, was the way Kareem Yusuf watched. Not patients only, everything. He watched the way supply carts were positioned at shift change and noted which locations created bottlenecks. He watched which of the junior nurses lost composure under pressure and which ones steadied, and he filed this away without comment. He watched the loading dock from the break room window during his lunch and tracked how long it took ambulances to navigate the vehicle congestion on arrival, 4 minutes longer than it should have been, due to an easily correctable parking arrangement that no one had bothered to correct. He did not share these observations socially. He documented them in a small gray notebook that he kept in the breast pocket of his scrubs. No one had ever asked to see the notebook. No one had ever asked about it. On the morning of Thursday, the 9th, 3 days before the crisis, Kareem administered medications to his 6 assigned patients, updated 3 care notes, flagged an early-stage infection in Bay for that the overnight physician had not recorded, and filed the flag before 8 a.m. The infection flag would later save that patient an additional week of hospitalization. No one connected the flag to Kareem. It was simply processed and acted upon the way competent, invisible work is always processed and acted upon without attribution, without ceremony. At 8:23 a.m., Kareem sat in the break room with a cup of tea he had made himself and a medical journal he had brought from home. The journal was not new. Its spine was broken. Certain pages had been folded at the corner, not randomly, but with the selective precision of someone who had read the entire volume and kept only what was worth returning to. Nurse Priya Desai sat across from him with her phone and a croissant and said, without looking up, "You ever take a day off, Kareem?" He turned a page. "I'm here," he said. She laughed, assuming it was deflection. It wasn't. It was a complete answer. At 9:05 a.m., Deputy Director Marcus Harlan held his weekly floor review in the small glass-walled conference room adjacent to the nursing station. Kareem was not required to attend. He attended anyway, standing near the back wall, arms folded, gray notebook in his breast pocket. Harlan was 51 years old, recently promoted from regional administration, and possessed of the particular confidence of a man who had learned to navigate bureaucratic systems so effectively that he had mistaken this skill for expertise. He spoke in the vocabulary of institutional management efficiency frameworks, resource alignment, departmental throughput, and the clinical staff listened with the patient resignation of people who had learned that arguing with administration required more energy than the outcome was worth. Halfway through the meeting, Harlan displayed a revised emergency triage flow chart on the projector screen. Kareem looked at it for 4 seconds. Then he looked at the floor. Then he took the gray notebook from his pocket and wrote something in it, slowly and deliberately, in a way that Harlan did not notice and Dahlia Osman did. She watched him write. She did not ask what he had written. Later, she would wish she had. The meeting ended at 9:47 a.m. Kareem returned to the floor, completed his mid-morning patient checks, assisted a junior technician with a malfunctioning foreline, and ate his lunch rice and lentils from a container he had prepared at home standing at the break room counter, reading. By 2 p.m., his shift was complete. He signed out, collected his jacket from his locker, and walked to the elevator. Dahlia Osman watched him go. Hard to read, she had written. She stood at the nursing station and thought, not for the first time, that this was not entirely accurate. He was not hard to read. He was simply reading something else entirely, something the rest of them could not yet see. She did not know what to do with that thought, so she set it aside. 3 days later, she would not have that option. The formal suspension letter was printed on hospital letterhead. It was dated Tuesday the 7th. It cited 1 count of insubordination, 1 count of disrupting a departmental review meeting, and 1 count of, and this was the phrase that Kareem read twice, not from anger but from something closer to clinical interest, creating unnecessary alarm among staff regarding established emergency protocols. He folded it once, placed it in his jacket pocket, closed his locker, and left. No phone call to a union representative. No request for a formal hearing. No conversation with Dahlia Osman, who had been standing near the nursing station when security delivered the letter and who had watched the entire exchange with an expression she could not entirely control. He simply left. It was this, not the suspension itself, not the letter, not even the circumstances that produced it, that stayed with Dahlia Osman for the next 72 hours. A man who accepts removal from a building he has done nothing wrong in, without a single word of protest, is not a man who has been defeated. He is a man who has already calculated that the argument is not worth having here. It had begun 4 days earlier. Sunday the 5th. Kareem had been completing his end-of-shift documentation when he pulled up the hospital's current mass casualty incident protocol. Not because he had been asked to, but because he had been thinking about the triage flow chart from Harlan's Thursday meeting, and something in it had continued to surface in his mind the way a wrong note in music continues to surface even after the song has ended. He read the full MCI protocol document in 40 minutes. Then he read it again. Then he opened the gray notebook and began writing. Not notes, a structured analysis, section by section, failure point by failure point, of exactly where the protocol would break down under real mass casualty conditions. He identified 6 critical vulnerabilities. The most serious, the secondary triage zone, was positioned adjacent to the main ambulance bay, which meant that during a high-volume event, patient intake and patient sorting would occur in the same physical space, creating a human traffic collision that would slow both processes by an estimated 40%. He had seen this exact failure before. He did not write where. He simply marked it, critical, systemic delay will cost lives. The second most serious, the blood supply routing listed in the protocol directed surgical grade reserves through a corridor that, due to a renovation completed 8 months prior, no longer existed in that configuration. Someone had updated the building. No one had updated the protocol. He documented all 6, clearly, with proposed corrections for each. On Monday morning, he submitted the document through the hospital's formal incident reporting system, addressed to the chief medical officer and copied to the head of emergency services. He received an automated acknowledgement at 9:14 a.m. He received no further response. On Tuesday morning, he submitted it again, this time as a direct written memo to Deputy Director Harlan. Given that Harlan had presented the triage revision in Thursday's meeting and therefore held current administrative authority over the protocol, Harlan read the memo during his 10 a.m. coffee. He forwarded it to his administrative assistant with a single line: "File under departmental feedback." At 2:30 p.m. Tuesday, Kareem attended the weekly department's safety meeting, a meeting he was not scheduled to attend but was not prohibited from attending. When the agenda reached any other business, he raised his hand. Harlan recognized him with a particular expression of someone who already knows this will be inconvenient. Kareem spoke for 4 minutes. He did not raise his voice. He did not use dramatic language. He presented his 6 findings in the same sequence he had documented them, with the same precision, in the same measured tone he used for everything. He recommended immediate protocol revision before the coming weekend, citing the industrial complex on Faro Road, currently operating beyond safe capacity, flagged twice in the past year by municipal safety inspectors, as a probable near-term mass casualty source. The room was quiet when he finished. Harlan looked at him for a moment. Then he said, "Thank you for that, Kareem. We'll take it under advisement." The meeting moved on. Kareem sat with his hands folded on the table for the remainder of the meeting. He did not speak again. When it ended, he returned to his floor, completed his shift, and went home. The suspension letter arrived the following morning. Harlan had drafted it the previous evening. After the meeting, after his second coffee, after a phone call with the hospital's HR liaison in which he described Kareem's presentation as alarmist behavior causing unnecessary distress to clinical staff. The HR liaison, who had never met Kareem and had no context for the protocol document, approved the letter within the hour. It was efficient. It was clean. It resolved an irritation. It was also, though neither man would understand this for another 72 hours, the single most consequential administrative decision in the recent history of St. Aurelius General Hospital. Not because it was wrong, though it was wrong, but because of what it assumed. It assumed that Kareem Yusuf was the kind of man who could be removed from a situation. At home on Wednesday evening, Kareem cooked a simple meal, read for 2 hours, and went to bed at 10 p.m. His phone showed the news alert at 10:52 p.m. Breaking: major structural fire reported at Faro Road Industrial Complex. Multiple casualties expected. Emergency services responding. He read it once. He set the phone face down on the nightstand. He lay in the dark for exactly 90 seconds. Then he sat up, reached for his jacket hanging on the chair beside the bed, and checked the breast pocket. The gray notebook was there. He put the jacket on. The drive to St. Aurelius General took 11 minutes. Kareem did not drive fast. He drove at exactly the speed that traffic and signal timing permitted, taking the route he knew would be clearest at this hour. Not the most direct route, but the most reliable one. There is a difference. He had learned this distinction in conditions where the wrong choice cost more than time. He did not call ahead. He did not call anyone. The radio in his car picked up the emergency frequency out of habit. An old habit, one he had never bothered to break. And he listened without expression as the dispatch communications build a picture in real time. First unit on scene reporting structural collapse on the eastern wing of the Faro Road complex. 40 confirmed injured, number rising. Burn casualties, crush injuries, smoke inhalation. 6 ambulances dispatched. Request for additional units. Then, all major trauma casualties routing to St. Aurelius General. Nearest level 2 facility. He turned the radio off. He already knew what he would find when he arrived. St. Aurelius General at 11:08 p.m. on a weeknight was not the same building it was at 9 a.m. on a Tuesday. At 9 a.m., it operated on full staffing, full administrative presence, full supply chain availability. Problems were managed. Hierarchies functioned. The system, flawed as it was, held its shape because enough people were present to hold it. At 11:08 p.m., it ran on a skeleton. One attending physician, Dr. Rajan Mehta, 12 years in emergency medicine, competent and exhausted. covering the entire emergency floor. 4 nurses across 2 units, 2 orderlies, 1 radiology technician on call, a security guard at the front desk who was 23 years old and had been on the job for 6 weeks. This was the architecture that was about to receive 57 trauma patients in under 40 minutes. Kareem parked in the staff lot. His access card had been deactivated with the suspension, but the parking barrier was manually operated after 10 p.m. by the security desk, and the young guard waved him through without checking his credentials because there was already too much happening for credential checks. He walked toward the emergency entrance. From 30 meters away, he could already hear it. The sound of a hospital receiving more than it can hold is not a loud sound, precisely. It is not screaming, or not only screaming. It is the sound of a system at the edge of its capacity, making small structural failures in rapid succession. Voices overlapping without resolution. Equipment being moved without clear destination. Questions being asked without anyone positioned to answer them. Kareem had heard this sound before, in a field hospital in a country whose name he did not say aloud anymore. In a transport facility during a border crisis that was never officially classified as a crisis. In a gymnasium converted to a medical station after an event that still did not appear in any public record. He had heard this sound, and he had learned through training, through repetition, through cost, exactly what it meant and exactly what needed to happen in the first 4 minutes after you heard it. He pushed through the emergency entrance doors. The scene inside was operating at the precise edge where functional chaos tips into systemic failure. The triage area, designed to process 8 patients simultaneously, had 14 people in it. 3 were on gurneys. 4 were on the floor with makeshift padding beneath them. 2 were standing and appeared ambulatory, but were showing signs of shock that no one had yet flagged. The remaining 5 were family members or bystanders who had arrived with patients and had not been redirected. The triage board, the central coordination tool for patient status and routing, showed 8 entries, 4 of which were already incorrectly classified based on what Kareem could observe from the doorway with a single visual pass. Nurse Priya Desai was at the main station, phone pressed to her ear, writing on a notepad with her other hand, her face carrying the specific expression of someone managing 4 things simultaneously and losing ground on all of them. Dr. Mehta was crouched beside a gurney in Bay 2, working. His hands were occupied. His attention was fully committed. He was doing exactly what he should be doing, treating the patient in front of him, which meant no one was watching the room. No one was watching the room. This was the failure. Not any individual person. Not any single decision. The failure was architectural. The same failure Kareem had documented 6 days ago in a memo that had been filed under departmental feedback and forgotten. The room had no coordinator. Without a coordinator, a mass casualty floor does not slow down. It accelerates toward disorder, toward misroute, toward preventable death. Kareem stood at the entrance for 3 seconds. 3 full seconds, long enough to complete a visual survey of the entire space, assign a mental status to every patient he could see, identify the 2 most immediately critical misclassifications, locate the supply positions, map the personnel, and calculate the order of his first 5 actions. 3 seconds. Then he walked in. He did not announce himself. He did not go to the nursing station and explain who he was or why he was here or what authority he was or was not operating under. He did not ask for permission. He did not make a speech. He walked directly to Bay 3, where a male patient in his 40s, classified on the triage board as priority 3, non-critical, was sitting upright against the bay wall with his hand pressed to the left side of his neck and his lips carrying the faint blue tinge of a man whose airway situation was not going to remain stable for more than another few minutes. Kareem crouched beside him. He placed 2 fingers at the patient's throat. He watched the chest. He noted the tracheal position. He stood up, walked to the supply cart, took what he needed, and returned. 30 seconds had passed since he entered the building. Nobody had noticed him yet. That was fine. He was not here to be noticed. The patient's name, Kareem would learn later, was Tariq Salim, 44 years old, warehouse supervisor at the Faro Road complex. He had been standing near the eastern corridor when the structural beam came down. Not on him, but close enough that the pressure wave had done something to his left side that the paramedics who brought him in had classified, in the noise and urgency of transport, as a probable soft tissue injury. It was not a soft tissue injury. What Kareem's two-finger assessment had confirmed in 11 seconds was a developing tension pneumothorax. Air accumulating in the pleural cavity, compressing the lung, beginning to shift the heart and great vessels away from their correct positions. The tracheal deviation was subtle but present. The breath sounds on the left were diminished. The bluish tinge at the lips was not severe yet. But it was a clock, and the clock was not running slowly. Without intervention, Tariq Salim had perhaps 4 minutes before the pressure became incompatible with a functional heartbeat. He had been sitting against a wall in Bay 3 for 11 minutes. Kareem did not allow himself to think about those 11 minutes. There was no utility in it. The time was gone. What remained was now, and now was manageable. He opened the supply tray he had pulled from the cart. Large-bore needle, antiseptic, gloves. He worked with the particular economy of motion of someone who has performed a procedure enough times that the body does it while the mind remains free to watch the room. "Sir," he said to Tariq quietly, "I need you to stay very still. This will feel like pressure. It will help you breathe." Tariq looked at him with the unfocused eyes of a man running on adrenaline and confusion. He nodded once. Kareem located the second intercostal space, midclavicular line, cleaned the site, inserted the needle. The hiss of released air was immediate and unmistakable. Tariq Salim took his first full breath in 11 minutes. His lips began returning to their correct color before Kareem had finished securing the needle. "Excuse me." The voice came from behind him. Kareem finished securing the needle before he turned. Charge nurse Amara Nwosu was standing at the entrance to Bay 3. She was 38 years old, 8 years in emergency nursing, and she was looking at Kareem with an expression that contained equal parts exhaustion, confusion, and institutional reflex. "You're the suspended nurse," she said. It was not a question. "Yes," Kareem said. "You can't be here. You don't have clearance to look at his lips," Kareem said. She looked. Tariq Salim was breathing. Visibly, fully, the color returning to his face in real time. She looked back at Kareem. "Tension pneumothorax," he said. "Triage board had him as priority 3. He needed needle decompression 4 minutes ago." He paused. "He's stable now. He'll need a chest tube within the next 30 minutes, but that can wait for Dr. Mehta." Amara Nwosu looked at the patient, at the needle, at the triage board visible through the bay entrance, where Tariq's priority 3 classification sat unchanged. She was quiet for 3 seconds. "You still don't have authority to Bay 7, Kareem said, already moving past her. "The woman in the gray jacket. She's been classified as priority 2, but she's showing signs of internal abdominal bleeding. She needs to be moved to priority 1, and she needs imaging before Dr. Mehta finishes with his current patient." Amara turned and looked at Bay 7. The woman in the gray jacket was lying on a gurney, very still, with her eyes half open and her skin carrying the particular pallor of volume loss that is easy to miss when you are managing 14 patients at once and impossible to miss when someone points directly at it. Amara looked at the woman for 2 seconds. Then she turned back toward the nursing station and called across the floor, "Priya, Bay 7, move her to priority 1. I need imaging prep now." She did not look at Kareem again as she said it. She did not need to. Kareem moved to the triage board. He did not ask permission. He picked up the marker, the same marker that had been sitting in its tray since the board was last updated 20 minutes ago, and made 2 corrections. Clean, precise, the handwriting of someone who has written on boards like this in conditions far less stable than this corridor. A junior nurse named Felix Okafor, 26 years old and 7 months into his first hospital posting, watched from the station. He watched Kareem correct the board. He watched him move to Bay 7 and check the patient Amara had just reclassified. He watched him pause at the supply cart and reposition 3 items, not randomly, but deliberately, the way you reposition tools when you know exactly what the next hour is going to require. Felix had graduated near the top of his class. He was not inexperienced, but he understood, watching this, that he was observing a different category of knowledge than anything his training had prepared him for. It was not smarter. It was not more technical. It was simply older, worn-in, load-tested, shaped by pressure he could not yet imagine. He made a decision, standing at the nursing station, without fully articulating it to himself. He was going to follow whatever this man did. Not because he was told to, because it was obviously correct. At 11:24 p.m., Dr. Rajan Mehta emerged from Bay 2, pulled off one pair of gloves, and looked at the floor. Something had changed since he went into that bay. The noise level was different, not quieter, but more directed. The movement of staff had a shape to it that it had not had before. The triage board had been updated. The supply cart had been reorganized. He looked around for the source. He found Kareem at Bay 5, conducting a rapid secondary assessment on a young woman with burns on her forearms and a confusion level that suggested something beyond smoke inhalation. "Who are you?" Mehta asked. Kareem did not look up from the patient. "Trauma Unit C, night rotation." This was not technically accurate, but it was not a lie that served Kareem. It was a lie that served the floor, because the floor needed Dr. Mehta focused on medicine, not on administrative anomalies. Mehta looked at him for one more second. Then he looked at the patient Kareem was assessing and recognized, from the positioning of Kareem's hands and the direction of his assessment, exactly what he was looking for and why. "Carbon monoxide?" Mehta said. "Possibly," Kareem said. "Confusion without proportionate physical trauma. I'd like to get a carboxyhemoglobin level before we route her." Mehta nodded. "Order it." "I don't have ordering authority," Kareem said. "You do." Mehta picked up the chart and wrote the order. Kareem moved to the next bay. By 11:31 p.m., 31 minutes after Kareem had entered the building, 23 minutes after the first wave of casualties had arrived, 4 patients who had been incorrectly classified were now correctly classified. 2 critical interventions had been performed. The triage board reflected reality for the first time since the crisis began. Nobody had announced that Kareem Yusuf was running the floor. Nobody had voted on it. Nobody had asked. The floor had simply reorganized itself around the one person moving through it who knew exactly where everything needed to go, the way water reorganizes itself around a stone placed in a current, not from force, but from the simple physical logic of the situation. Felix Okafor stood at the nursing station and watched it happen. He thought about it for a moment. Then he picked up the communication radio and began routing incoming ambulance reports to Kareem's position instead of the central station. It was the right call. He knew it without being told. That, too, was a kind of competence. At 11:33 p.m., the second ambulance wave arrived. Not one vehicle. 4. Simultaneously, the result of a dispatch coordination gap that had grouped the second priority casualties into a single transport window. They came through the emergency bay doors in rapid succession, gurneys moving fast, paramedics calling out vitals in the compressed shorthand of people who have been working a scene for 40 minutes and are running on adrenaline and professional discipline. 11 new patients in 4 minutes. The floor, which had just begun to find a fragile rhythm, absorbed the impact the way an undersized vessel absorbs a wave. Not capsizing, but listing, the carefully rebuilt order threatening to dissolve back into noise. Kareem was at the central corridor junction when the doors opened. He had been there for 90 seconds already. He had positioned himself there deliberately. At the geometric center of the floor's patient flow, the single point from which all 4 active bays, the triage board, the supply corridor, and the ambulance entrance were simultaneously visible. He had learned this positioning instinctively years ago in a context where the person standing at the center of a medical coordination space was not called a charge nurse. They were called something else. He did not think about that now. He watched the gurneys come through the doors and began sorting in his mind before the paramedics finished their handoffs, processing visual information, vital sign callouts, and injury patterns simultaneously, building a mental map of 11 patients in the time it took most people to process 2. Then he began to speak. Not loudly. Never loudly. This was one of the things Felix Okafor would remember later. Not the content of what Kareem said, but the volume, or rather, the absence of volume. In a floor that was running on raised voices and urgent calls, Kareem operated at a register just above conversational. It meant people had to pay attention to hear him. It meant they leaned in slightly. It meant that when his voice reached you, you were already oriented toward it. Felix, incoming in Bay 6, crush injury, probable compartment syndrome, right lower leg. Get Dr. Mehta's attention before he commits to his next patient. Felix moved. Priya, the man on the second gurney, paramedic called burns at 30%, but look at his breathing pattern. He's splinting. Query rib fractures. Don't route him to the burns bay. Route him to imaging first. Priya looked. Priya rerouted. The woman behind him. She's ambulatory. She's been walking since she came through the door, but she sat down against the wall 40 seconds ago and hasn't moved. That's a change in status. Someone needs to be with her in the next 2 minutes. Amara Nwosu, passing with a supply tray, changed direction without being asked. It went like this. Not orders, exactly. Observations delivered with such precision and such obvious clinical foundation that the response they generated was not obedience, it was recognition. The staff were not following Kareem because he had authority. They were following him because everything he said when they looked was correct. And there is a particular kind of trust that builds in a crisis when someone is correct, not once, not twice, but continuously, that bypasses hierarchy entirely and operates at a more fundamental level. The level of survival. Between 11:33 p.m. and 11:54 p.m., Kareem rebuilt the floor's patient flow system from the inside. He did not call a meeting. He did not produce a document. He did not stand at a whiteboard and diagram his intentions. He built it in motion, decision by decision, placement by placement, the way an experienced military logistics coordinator builds a field supply chain, not from a plan imposed on reality, but from a plan extracted from reality as it is actually presenting itself. The triage board, which had been a source of confusion since the crisis began, became under his management something different. He had Felix updated in real time. Not the standard color coding system the hospital protocol specified, which had too many categories and too much visual complexity for a high-volume event, but a simplified 3-tier system. Immediate, controlled, waiting. 3 colors. No ambiguity. Readable from 10 meters in 3 seconds. When Amara questioned the deviation from protocol, Kareem answered her directly. The protocol was written for 8 patients. We have 23. A system designed for 8 patients managing 23 patients is not a protocol anymore. It's a bottleneck. She looked at the board, at the floor, at the movement happening around them. She did not argue further. Personnel placement was the element that revealed, to those paying close enough attention, that what Kareem was doing was not improvisation. Improvisation has a texture, reactive, slightly ragged, built on instinct and correction. What Kareem was doing had a different texture entirely. It was constructed. Each person placed in each position reflected not just the current state of the floor, but an anticipation of what the floor would need in 15 minutes, in 30 minutes, in the hour ahead. Felix Okafor became the communication anchor. This was not an obvious choice. Felix was 7 months into his first posting, junior by almost every institutional measure. But Kareem had watched him for 20 minutes and identified 3 things. He processed incoming information quickly, he communicated outgoing information without distortion, and, critically, he did not panic when the volume increased. He became quieter when the noise rose, not louder. This was rare. This was valuable. Kareem positioned him at the central station with the radio, the triage board, and explicit authority to redirect ambulance routing calls. Authority that technically required a charge nurse designation, but which, in the operational reality of the floor at 11:40 p.m., required only that the person in the position knew what they were doing. Felix knew what he was doing. He had learned it by watching Kareem for 20 minutes. Emmanuel Addo was 61 years old and had worked as an orderly at St. Aurelius for 19 years. He had the specific gravity of a person who has spent 2 decades in proximity to human suffering without being destroyed by it. Not because he was unfeeling, but because he had developed, through years of quiet witness, a way of being present with people in crisis that was neither clinical nor sentimental. He was exactly the right person to manage the family and bystander area. This was the area no one was managing. When a mass casualty event floods a hospital, the patients are not the only crisis. The people who arrive with the patients, or who arrive looking for the patients, create a secondary pressure system that, if unmanaged, bleeds into the clinical space and degrades it. Families asking questions at the wrong stations. Bystanders in states of shock occupying triage spaces. People grabbing at staff members who cannot stop moving. Kareem found Emmanuel in the supply corridor at 11:42 p.m. "I need you in the family area," he said. "Not to give information. We don't have information to give yet. Just to be there. Keep people in the designated space. If someone starts to deteriorate emotionally, stay with them. If someone becomes physically disruptive, call security. Can you do that? Emmanuel looked at him. I've been doing that for 19 years, he said. Nobody ever asked me to. I'm asking, Kareem said. Emmanuel took off his supply gloves and walked toward the family area. Within 8 minutes, the secondary pressure system had a shape. People were contained. Not coldly, not mechanically, but humanly, with Emmanuel moving through the space with his 19 years of quiet witness and his particular ability to make people feel that someone was present with them even when nothing could be resolved. It was not a medical intervention. It was not in any protocol. It reduced the clinical floor's disruption load by more than any piece of equipment could have. At 11:51 p.m., Dr. Mehta stepped out of Bay 4 and stood for a moment in the corridor. He looked at the floor. It was not the same floor it had been 40 minutes ago. It was not calm. It could not be calm, not with 26 patients now in various stages of assessment and treatment. But it had a quality that the floor had not possessed when he had entered Bay 2 at the beginning of the crisis. It had shape. He could see the triage board from where he stood and read it in 4 seconds. He could see where each staff member was and understand why they were there. He could see the patient flow moving in a direction, intake to assessment to treatment to stabilization, instead of circling in the formless loop it had been running when the first ambulances arrived. He looked for Kareem and found him at Bay 8, speaking quietly to a young male patient with bandaged hands, taking a history. In the middle of all of this, because the history mattered, because a history taken now would save time later, when the patient reached the next stage of treatment, and Kareem had calculated that the 60 seconds it cost him to take it would save 4 minutes downstream, and those 4 minutes belonged to someone else who needed them. Mehta watched him for a moment. Then he said, to no one in particular, to the corridor perhaps, or to himself, "Where did this man come from?" Nobody answered. The floor kept moving. At 11:54 p.m., Felix Okafor's radio produced a new voice. Deputy Director Marcus Harlan. This is Harlan. I'm en route to the facility. ETA 12 minutes. I want a full status report ready when I arrive, and I want to know who authorized the protocol deviation on the triage board. Felix looked at the radio. He looked across the floor at Kareem. Kareem was still at Bay 8. He had heard the transmission. Felix could tell by the slight stillness that passed through him, a fractional pause in his movement, like a man who has just registered a change in weather. Then he continued taking the history. Felix pressed the radio transmit button. Copy that, sir. Status report will be ready. He set the radio down. He looked at the triage board. At the floor. At 26 patients in various stages of survival. He thought about Deputy Director Harlan, en route, 12 minutes away, wanting to know who had authorized the protocol deviation. He thought about what the floor had looked like 40 minutes ago. He picked up a pen and began updating the triage board. He had work to do. Harlan could wait 12 minutes. Marcus Harlan arrived at 12:03 a.m., not 12 minutes 11. He had driven faster than he told the radio, which was consistent with who he was. A man who liked to arrive before people expected him, because arriving early was a form of control, and control was the currency Harlan had spent his entire career accumulating. He came through the emergency entrance in a gray suit jacket over a collared shirt. He had been at a dinner when the call reached him, a budget review dinner with 2 board members, the kind of dinner that mattered for the kind of reasons that had nothing to do with patient care. He had his hospital ID clipped to his lapel and his phone in his hand, and the expression of a man who has already decided what he is going to find before he has found it. He stopped just inside the entrance. He looked at the floor. Whatever he had expected, whatever version of productive chaos or managed disorder he had prepared himself for, this was not it. The floor was moving. Not perfectly, not without strain, but with a coherence that a mass casualty event at this volume and this staffing level had no business possessing. The triage board was updated and readable. Staff were in positions that made sense. The patient flow had direction. The family area was contained with Emmanuel Addo visible through the glass partition, seated beside an older woman, speaking to her quietly. Harlan stood and looked at this for 4 seconds. Then his eyes found the triage board. The triage board with its 3 simplified categories: immediate, controlled, waiting, written in a handwriting that was not Amaran Wosu's, and was not Priya Desai's, and was not anyone on his authorized staff roster. His jaw tightened. He began moving toward the central station. Felix Okafor saw him coming. He had been watching the entrance since the radio call, not with anxiety exactly, but with the careful attention of someone who understands that a new variable has entered a system that is currently balanced, and that new variables in balanced systems require management. "Mr. Harlan," he said as Harlan reached the station. "I have the status report ready. Where is he?" Harlan said. Felix did not ask who. "Bay 8, sir." Harlan did not take the status report. He walked toward Bay 8. Kareem was at the bay entrance reviewing a chart update that Felix had passed him 2 minutes earlier when Harlan's footsteps reached him. He did not need to look up to know who it was. The pace was wrong for clinical staff, too purposeful, too directed, carrying the specific rhythm of someone moving toward a confrontation rather than toward a patient. He finished reading the chart update. Then he looked up. Harlan stopped 3 feet away. He was a larger man than Kareem, broader, with the physical confidence of someone accustomed to occupying space as a statement. He looked at Kareem the way he had looked at him in the department's safety meeting 6 days ago, when Kareem had presented his protocol analysis and Harlan had said, "Well, take it under advisement." The same look, measured, dismissive, already decided. "You are suspended," Harlan said. His voice was low, controlled. He was not shouting. He was too experienced for that. "You don't have credentials to be in this building. You don't have authority to touch a patient, restructure a floor protocol, or direct clinical staff. You were removed from this facility 3 days ago." He paused. "Security is going to escort you out." Right now, Kareem looked at him. He did not move. He did not straighten his posture or shift his weight or perform any of the physical adjustments that people make when they are preparing to assert themselves. He simply stood as he had been standing, still, balanced, present, and looked at Harlan with an expression that contained neither anger nor apology. The absence of both seemed to unsettle Harlan more than either would have. "Mr. Harlan," Kareem said. His voice was the same volume it had been all night. Quiet, even. The kind of voice that requires a room to adjust to it rather than adjusting itself to the room. "I'm going to say 5 things. I'd like you to listen to all 5 before you respond." Harlan's eyes narrowed slightly. He did not speak, which was, Kareem understood, permission enough. "First," Kareem said, 31 patients have been triaged, assessed, and routed in the last 90 minutes. Of those, 7 were in immediately life-threatening conditions that were not identified on initial triage. All 7 have been stabilized or are currently in active treatment. Without the corrections made in the last 90 minutes, the probability that all 7 would have been identified in time is low. You can review the board and the timestamps and reach your own conclusion about that." He paused. Not for effect, simply because he spoke in complete units of thought, and the first unit was complete. Second, the triage protocol deviation, you're looking at the 3-category system on the board, is not an unauthorized modification. It is a field adaptation consistent with WHO mass casualty management guidelines for events exceeding standard facility capacity. The original protocol was designed for 8 simultaneous patients. We currently have 31. A protocol operating beyond its design parameters is not a protocol. It is a liability. Another pause. Harlan's expression had not changed, but something behind it had shifted, a slight recalibration. The look of a man who came prepared for an argument and has instead encountered a technical briefing. Third, the staff currently operating this floor have not been redirected away from their responsibilities. They have been positioned within their responsibilities more effectively. Dr. Mehta is treating patients. The nursing staff are treating patients. The deviation from normal hierarchy tonight is one of coordination, not authority. The clinical decisions remain with the clinicians. He looked at Harlan steadily. Fourth, there are currently 26 patients in active status on this floor. 3 of them are in conditions that will require physician attention in the next 15 to 20 minutes. If you remove me from this building right now, the coordination structure that is currently managing those transitions goes with me. What replaces it tonight at this hour with this staffing level is nothing. You know that. The corridor was not quiet. The floor was still moving around them, voices, equipment, the sounds of a mass casualty event in its 3rd hour. But the space between Kareem and Harlan had a particular stillness in it, the way the center of a current can be still while everything around it moves. Kareem said the 5th thing. 5th. I submitted a formal protocol analysis to this department 6 days ago, identifying every failure point that is currently active on this floor tonight. It was filed under departmental feedback. I am not telling you this to assign blame. I am telling you this because you are the administrative authority in this building tonight, and you need to know the complete picture of what you are managing. The picture includes that document. He stopped. He waited. Harlan stood in the corridor for a long moment. Later, much later, in the privacy of his own home, in the particular sleeplessness of a man replaying a night he cannot fully account for, he would try to identify exactly why he did not call security. It was not fear. It was not admiration. It was not even entirely the clinical logic of what Kareem had said, though the logic was sound and he knew it. It was something in the fifth point, the fact that Kareem had not used it as a weapon. He had the weapon. He had submitted the document. He had been correct. He had been suspended for being correct, and now the exact failure he had predicted was unfolding in exactly the way he had predicted it, and he was standing in the middle of it holding the floor together with 11 months of nursing experience and whatever else he clearly was, and he had delivered that information as a briefing, not as an accusation, not as vindication, as a briefing, because the floor needed Harlan to have the complete picture, and Kareem's personal grievance was irrelevant to the floor's needs tonight. And so he had set it aside as cleanly and completely as he had set aside everything else that was irrelevant tonight. Harlan had spent 26 years in healthcare administration. He had never encountered anything like this. He looked at Kareem for 3 more seconds. Then he said, very quietly, "Carry on." He turned and walked to the central station, where Felix Okafor was waiting with the status report. He took it. He read it. He did not interfere again. Kareem watched him go. Then he turned back to Bay 8. There was a patient waiting. There was always a patient waiting. He went back to work. At 12:09 a.m., the 4th ambulance wave arrived. It was smaller than the others, 3 vehicles, not 4, carrying the last confirmed casualties from the Faro Road site. The fire crews had completed their primary sweep. The structural collapse had been contained. What came through the emergency doors in these final vehicles was the remainder. The people who had been harder to reach, trapped longer, found later in the search grid. Among them, on the 3rd gurney of the 3rd vehicle, was a 7-year-old girl. Her name was Nadia. She had been at the industrial complex with her father, who worked the night supervisory shift and had brought her because the babysitter had canceled and there was no other arrangement, and it was supposed to be a quiet night. Just a few hours, she would sleep in the break room on a folded jacket. It would be fine. It had not been fine. She came in conscious but confused, with superficial burns on her right forearm and a laceration above her left eyebrow that had bled considerably but was not, in itself, serious. The paramedic handoff classified her as Priority 2, urgent but stable. She was placed on a gurney in the intake corridor and assigned to Bay 9, the pediatric adjacent space at the far end of the emergency floor. Bay 9, which was, at 12:09 a.m., on the wrong side of a routing decision that had been made before Kareem restructured the floor. The routing error was not complex in origin. When Kareem had rebuilt the patient flow system at 11:40 p.m., he had worked with the floor as it existed at that moment. 23 patients for active bays, a specific set of personnel in specific positions. He had restructured around that reality. He had built contingencies for the 3rd wave. He had could not have, fully accounted for a 4th wave arriving after the system had already settled into its new rhythm, because the dispatch information available at 11:40 p.m. had indicated 3 waves, not 4. The paramedic who handled Nadia's intake was a young man named Declan, 28 years old, 6 months in emergency transport, working his first mass casualty event. He had followed the intake procedure correctly: handoff, classification, bay assignment. The bay assignment he used was from the original protocol routing chart, not the revised system Kareem had implemented. Bay 9 was correct under the original system. Under the revised system, a pediatric patient presenting with confusion and possible smoke inhalation was supposed to be flagged at intake and routed to Bay 6, where Priya Desai had been positioned specifically because she had pediatric emergency training. Bay 9 had no assigned staff. At 12:09 a.m., Nadia was placed in Bay 9 on a gurney, her small hands folded on her stomach, her eyes tracking the ceiling slowly, and no one was with her. Felix Okafor caught it at 12:14 a.m. He caught it not because the intake system flagged it. It didn't, but because he had been maintaining a mental count of patient locations since Kareem positioned him at the central station, and when he updated the triage board with the fourth wave's arrivals and placed the pediatric patient in Bay 9, something in the placement felt wrong against the system he had been running in his head for the past 30 minutes. He checked the revised routing chart Kareem had given him verbally at 11:45 p.m. He checked it against the board. He picked up the radio. Kareem, Bay 9. Pediatric intake, fourth wave. Wrong bay. There was a 2-second pause. Then, how long? Felix checked the intake timestamp. 5 minutes. Another pause. Shorter. I'm going. Kareem covered the distance from Bay 4 to Bay 9 in 40 seconds. He moved quickly but not at a run. Running in a hospital corridor during a mass casualty event creates secondary disruption, causes staff to redirect attention, generates alarm in patients who are already in states of acute stress. He had learned this. He moved at the fastest pace that did not disturb the system around him. He pushed through the Bay 9 curtain. Nadia was on the gurney. She was awake. Her eyes found him when he entered. Dark eyes. Very still. With the particular quality of a child who has been frightened beyond the reach of tears and has arrived at a place beyond crying that is quieter and more concerning than crying. Her breathing was audible from the doorway. Not labored. Not yet, but shallow. Rapid. The specific pattern of a small chest working harder than it should be to move air that is not moving as freely as it should. Kareem was beside her in 3 steps. He placed his hand on her sternum. Gently, the way you place a hand on a child. Not as a clinical instrument, but as a human presence first, because she was 7 years old and she was alone and she was frightened, and frightened children breathe worse than calm ones. And making her calm was part of the treatment. Hey, he said, quietly, the same volume as always. My name is Kareem. I'm going to help you breathe better. Can you tell me your name? She looked at him. Nadia, she said. Very small. Nadia. Good. You're doing well. I need you to try to breathe slowly with me. Can you watch my hand? He placed his hand on his own chest and breathed, deliberately, visibly slow and full. She watched his hand. She tried. Her breathing began to slow. Junior nurse Felix had called Priya Desai to Bay 9 as soon as he identified the routing error. She arrived 40 seconds after Kareem, slightly breathless, with a pediatric assessment kit and the focused expression of someone who has shifted gears completely. Between them, Kareem managing Nadia's immediate respiratory presentation, Priya conducting the full pediatric assessment. They work the bay with the quiet efficiency of people who do not need to narrate what they're doing to each other because the actions speak their own language. Elevated carboxyhemoglobin. Mild. Supplemental oxygen, flow rate adjusted for pediatric weight. Laceration cleaned and dressed. Secondary assessment clear. No internal injury. No fractures. No further respiratory compromise beyond the carbon monoxide component. At 12:31 a.m., Nadia was stable. She was breathing with the assistance of supplemental oxygen. Her color was returning, and she was looking at the ceiling with the slow, tired eyes of a child who has been frightened and is now, for the first time in 2 hours, safe enough to feel it. Priya sat beside the gurney, one hand near Nadia's, and said softly, "Your dad is in the building. We're going to find him for you." Nadia's eyes filled. She did not cry. She was too exhausted to cry. But something in her face released. A held thing, let go, and she turned her head slightly toward Priya and closed her eyes. Priya looked up at Kareem. He was standing at the bay entrance. He was looking at Nadia. His face was the same face it had been all night. Controlled, present, unreadable to most people. But Priya had been working alongside him for the past hour, and she had developed, in the way that people develop understanding in compressed and extreme conditions, a sensitivity to the small signals beneath his stillness. There was something in his face right now that had not been there before. Not guilt, not exactly. Guilt implies a moral failure, and there had been no moral failure here. The routing error had been systemic, not personal. No one had been negligent. The system had produced the gap, and Nadia had fallen into it, and she was safe now, and it was over. But it was not guilt that required a moral failure. It was the weight of knowing that a child had been alone and frightened and at risk in a space that his system had not covered, and that the 5 minutes she had spent in Bay 9 without anyone, 5 minutes that had not, ultimately, cost her anything, had been 5 minutes that could have. He stood at the bay entrance for 40 seconds. Priya watched him and understood, without being told, that she was looking at a man who had carried costs like this before. Not here. Not in this building. Somewhere else, in some other version of this night, in some configuration of crisis that she did not have the context to imagine. He had stood outside a bay or a tent or a vehicle and felt this same weight and carried it forward into the next thing because there was always a next thing, and the only response to the cost was to continue. She did not say anything. There was nothing to say. At 12:33 a.m., Kareem's radio. Felix had given him a unit at 11:50 p.m., operating on the hospital's internal emergency channel, produced a new voice. Dr. Mehta, Kareem, Bay 2, Bay 4, and Bay 7 are all moving towards surgical threshold simultaneously. I need coordination across all 3 theaters. I need it now. Kareem looked at Nadia one more time. She was breathing. She was safe. He pressed the transmit button. Copy. 60 seconds. He pulled the bay curtain closed behind him, gently, the way you close a door on something that needs quiet, and walked back into the corridor. He did not look back. The floor was waiting. He went. The 3 patients were in bays 2, 4, and 7. Kareem stood at the corridor junction, his position the geometric center of the floor, and looked at the triage board for 11 seconds. 11 seconds of stillness in the middle of everything. Felix Okafor, watching from the central station, would later describe it as the only moment all night where Kareem appeared to stop. Not hesitate, there was no uncertainty in it. It was something different, the stillness of a person who is holding a very large and complex structure in their mind and ensuring that every element of it is correctly positioned before they begin to move it. Like a chess player who has already seen 12 moves ahead and is simply confirming, before they touch the piece, that the sequence is exactly as they calculated. Then he moved. Bay 2 held a man named Osei Mensah, 51 years old. Plant foreman. He had arrived in the second wave with burns across his upper torso and what the paramedic had classified as a probable cardiac event, atypical presentation, the kind that presents in the field as respiratory distress, and is only correctly identified when someone takes the time to run an ECG in a building that is currently managing 31 other patients. Dr. Mehta had run the ECG 20 minutes ago, between 2 other patients, and what it showed was not a classic infarction pattern, but something subtler and in some ways more dangerous. A STEMI equivalent that was progressing slowly, but was now, at 12:34 a.m., beginning to accelerate. Osei Mensah needed a catheterization lab. St. Aurelius did not have a catheterization lab. He needed transfer. Bay 4 held a woman named Saoirse Dempsey, 33 years old, administrative contractor who had been in the building for an evening audit when the fire started. She had been extracted from a collapsed interior stairwell with crush injuries to her lower left leg, and more critically, a developing abdominal presentation that had not been fully apparent on arrival, but which Dr. Mehta had flagged 20 minutes ago as query internal hemorrhage, spleen or liver, possibly both, the kind of injury that is survivable with surgical intervention and fatal without it. She was the most immediately time-critical of the 3. She needed an operating theater. St. Aurelius had 1 operating theater active at this hour. It was currently occupied. Bay 7 held a man named Robert Finn, 67 years old, retired. He had been passing the Faro Road complex on an evening walk when the initial explosion occurred and had been struck by debris, a piece of external cladding, non-penetrating but significant, that had impacted his right temple and produced a traumatic brain injury of moderate severity. He was conscious. He was oriented to person but not to place or time. He had a fixed and dilated right pupil that had developed in the last 15 minutes. He needed a neurosurgical consult. St. Aurelius did not have a neurosurgeon on site at this hour. 3 patients, 3 different critical needs, 3 resource gaps. This was not a medical problem anymore. It was a logistics problem. And logistics, the movement of critical resources across a complex system under time pressure with incomplete information, was something Kareem Yusuf understood at a level that had nothing to do with nursing school. He pressed the transmit button on his radio. Felix, I need 3 things simultaneously. 1. Give me St. Catherine's on the line. I need their cath lab status and transfer timeline for a STEMI equivalent, male 51. 2. Find out the current status of our OR, who's in there, how long until they're out, and whether the surgical team can move directly from their current case to an abdominal hemorrhage. 3. Give me a neurosurgical consult by phone. Nearest facility with neuro on call. I need someone talking to Dr. Mehta about Bay 7 in the next 10 minutes. Felix was already writing before Kareem finished. Copy. All three. Simultaneously, Kareem said. Not sequentially. Understood. Kareem released the transmit button and walked toward Bay 4. Saoirse Dempsey first. The most time-critical patient always first. She was awake when he entered. This was not reassuring. Patients with internal hemorrhage are sometimes paradoxically alert in the middle stages. The body's compensatory mechanisms maintaining consciousness even as the pressure drops, a physiological illusion of stability that can make the severity difficult to read for anyone who has not seen it before. Kareem had seen it before. He checked her pressure. It had dropped 4 points in the last reading. He checked her abdomen, guarding, rigidity, the involuntary muscular contraction of a body protecting an injury it cannot afford to have touched. He looked at her face. She was looking at him with the steady eyes of a woman who was frightened but was managing it, holding it at a distance through will and the particular human capacity for denial that sometimes, in medical contexts, kept people alive long enough to be saved. Am I going to be okay? She said. Kareem looked at her for 1 second. You're going to surgery, he said. That's the right place for what you need. Dr. Mehta is an excellent physician, and the surgical team here is competent. You're in the right building. He did not say yes. He did not say everything will be fine. He said what was true and what was useful, and she received it. He could see her receive it, with the relief of someone who needed honesty more than comfort. Okay, she said. Okay, he said. He stepped out of the bay and pressed transmit. Felix or status. Current case closing now. Surgical team estimates 12 minutes to turn over. 12 minutes. Saoirse Dempsey had 12 minutes. It would be close. Tell the surgical team to expect an abdominal hemorrhage directly after turnover. Give them Dr. Mehta's notes from Bay 4. I want the theater prepped for that specific presentation before they finish their current case. Do I have authority to? Tell them it's Dr. Mehta's instruction, Kareem said. He'll confirm when he's out of Bay 2. A pause. Copy, Felix said. At 12:41 a.m., Kareem was in Bay 2 with Osei Mensah. The transfer to St. Catherine's had been arranged. Felix had reached their cardiology unit in 4 minutes, which was faster than Kareem had estimated and reflected the particular competence that Felix had been demonstrating all night in small, consistent ways that added up to something significant. St. Catherine's had a cath lab available. Transfer time by ambulance, 19 minutes. Their interventional cardiologist had been briefed by phone and was preparing. The ambulance was already requested. But Osei Mensah was deteriorating faster than the transfer timeline. He was diaphoretic now, the cold sweat of a heart under profound stress. And his pressure had shifted and his color was wrong, and Kareem had been in enough situations to know that 19 minutes was not a number this man currently had. He needed to be stabilized here now, sufficiently to survive the transfer. Kareem worked the bay with the precise focus of someone who has reduced the entire world to a single room and a single patient. Aspirin, already administered by Mehta. For access, both arms. Oxygen. Continuous monitoring. He reviewed Mehta's medication notes and made one addition. Not a clinical order. He had no ordering authority, but a flagged recommendation on the chart in clear terms that Mehta would read and act on when he arrived. Mehta arrived in 3 minutes. He read the chart. He looked at Kareem. He administered the medication Kareem had flagged. He did not ask how Kareem had known to flag it. Some things in the middle of a night like this one are simply accepted. Bay 7 was the hardest. Robert Finn was 67 years old and had a fixed and dilated right pupil and a neurosurgical consult happening by phone. A registrar at Northgate General, competent but working from description and numbers alone, unable to see the patient, making recommendations based on data that Kareem relayed with the precise, structured brevity of someone who has given clinical handoffs in conditions where imprecision costs lives. The consult confirmed what the pupil already indicated. Rising intracranial pressure. The intervention needed was beyond what St. Aurelius could provide tonight. Transfer. Again. Northgate General. 31 minutes by road. Robert Finn looked at the ceiling with his one responsive eye and said, very quietly, to the room in general, "Am I dying?" Kareem was at the monitoring equipment. He did not look up immediately. He finished reading the number he was reading. Then he turned to Robert Finn and gave him his full attention. Not the divided, managing attention of someone tracking 6 things, but complete, present human attention. "You have a serious head injury," he said. "We are transferring you to a hospital that has the specific surgical capability to treat it. The transfer is arranged. The team there knows you're coming." Robert Finn considered this. "That's not an answer," he said. "No," Kareem said. "It isn't." They looked at each other. "Is there someone I should call?" Robert Finn said. "Tell me who," Kareem said. "I'll make sure it happens before you leave." Robert Finn told him. Kareem wrote the name and number in the gray notebook. He stepped out of the bay and handed the notebook, open to that page, to Emmanuel Addo, who had appeared in the corridor at some point in the last 10 minutes, drawn perhaps by the specific gravity of Base 7, or simply by 19 years of knowing where he was needed. "Before the transfer," Kareem said. Emmanuel took the notebook. He read the name. He walked toward the family area to find a quiet corner with a phone. At 1:09 a.m., Saoirse Dempsey went into the operating theater. At 1:11 a.m., the ambulance carrying Osei Mensah left for St. Catherine's. At 1:14 a.m., the second ambulance carrying Robert Finn left for Northgate General. At 1:17 a.m., all 3 patients were either in active surgical intervention or in transit to the appropriate facility. The floor went quiet, not silent. The monitors continued, the staff continued, the remaining patients continued their various processes of stabilization and recovery. But the particular high-frequency tension that had been running through the building since 11:08 p.m., the vibration of a system operating beyond its designed limits, dropped away. What remained was the ordinary sound of a hospital at work. Kareem walked to the corridor bench outside Bay 3. He sat down. He placed his hands on his knees and looked at the floor between his feet. He breathed. Around him, the staff moved with the slower, heavier rhythm of people coming down from sustained crisis, competent still, present still, but beginning to feel the weight of the last 2 hours settling into their bodies the way weight settles after you have been holding something for a very long time and have finally been permitted to set it down. Felix Okafor looked across the floor at Kareem, sitting on the bench. He had been watching him all night, learning from him, following him, building a model of what clinical coordination under real pressure looked like when it was done by someone who actually knew how. He looked at him now and saw something he had not seen all night. A man who was tired, not broken, not diminished, just tired, the specific, deep tiredness of someone who has given everything that was required and is now, for the first time in hours, allowing himself to simply exist without a task. Felix looked at the triage board. 31 patients, all accounted for, all routed, all receiving appropriate care. He looked back at Kareem. He thought about saying something. He decided against it. Some things did not need words. He turned back to the central station and began updating the final patient records. There was still work to do. There was always still work to do. Director Adil Siddiqui arrived at St. Aurelius General at 1:43 a.m. He had been watching the security feed from his home office since 11:30 p.m. Not because anyone had called him, but because he had a notification system on his phone that triggered when the emergency floor exceeded a certain patient threshold, and when it triggered tonight, he had opened his laptop and pulled up the cameras and watched. He had watched for 2 hours and 13 minutes without calling anyone, without intervening, without sending instructions. This was not passivity. Siddiqui was 63 years old and had spent 31 years in hospital administration and clinical leadership, the first 14 as a practicing physician before administrative responsibility had absorbed him entirely. He understood, watching the security feed, that what was happening on his emergency floor was either going to resolve or it wasn't, and that a phone call from the director at midnight to a floor managing a mass casualty event was not help. It was noise. So he had watched, and what he had watched had kept him very still and very quiet for 2 hours and 13 minutes. He came through the emergency entrance at 1:43 a.m. in a dark coat over his evening clothes. He had not changed, had not taken the time, and stood for a moment in the entrance the way Harlan had stood 4 hours earlier, looking at the floor. The difference was what each man saw. Harlan had seen a deviation from protocol. Siddiqui saw something else. He saw a mass casualty floor that had processed 57 patients in under 3 hours at a staffing level that should have produced catastrophic failure, and had not produced catastrophic failure, and was now settling into the careful, competent aftermath work of a floor that had held under extraordinary pressure. He saw Emmanuel Addo moving through the family area with the unhurried presence of a man who has been doing exactly the right thing all night. He saw Felix Okafor at the central station, updating records with the focused efficiency of someone 10 years beyond his experience level. He saw Amar Nwosu and Priya Desai at the nursing station, working through post-crisis documentation with the particular thoroughness of people who understand that the paperwork is not separate from the care. It is part of it. He saw Dr. Mehta emerging from a bay with the slow, careful movements of a physician at the end of a very long night, competent and exhausted in equal measure. And he saw, on the corridor bench outside Bay 3, a man in green scrubs sitting with his hands on his knees, looking at the floor between his feet. Siddiqui watched the man on the bench for 30 seconds. Then he walked toward him. Kareem heard the footsteps, different from Harlan's, slower, more deliberate, the footsteps of someone who is not moving toward a confrontation, but toward a conversation, a distinction that is audible if you have learned to listen for it. He did not look up until Siddiqui stopped in front of him. Then he did. Siddiqui looked at him for a moment. Then he sat down on the bench, not in a chair brought from an office, not standing above him in the posture of institutional authority. He sat down on the same corridor bench, in his dark coat and his evening clothes, beside a suspended nurse in green scrubs, and he was quiet for a moment. Then he said, "I watched the security feed." Kareem said nothing. "All of it," Siddiqui said. "From 11:30. Another silence. 57 patients," Siddiqui said. 3 transfers successfully coordinated. 1 pediatric presentation identified and stabilized after a routing error. 7 critical misclassifications corrected in the first 40 minutes. He paused. 2 of those 7 would not have survived the night under the original triage routing. The probability on that is not ambiguous. I've looked at the timestamps. Kareem looked at the floor between his feet. "The floor did that," he said. The staff needed someone to organize them," Siddiqui said. "I watched who did that." Silence. Siddiqui let it sit for a moment. He was not a man who filled silences out of discomfort. He had learned over 31 years that the most important things were often said in the space after a silence, not before it. Then he said quietly, "Who are you?" Kareem was still for a moment. Then he reached into the breast pocket of his scrubs. Not the gray notebook. Something else, something that had been in that pocket all night, that he had carried without reference or display, the way certain people carry certain things not as tools but as facts about themselves that exist whether or not they are ever produced. He held it out to Siddiqui. A card. Small. Folded once. The paper was not hospital paper. It was heavier, more formal, the kind of paper that belongs to institutions that do not need to advertise their significance. Siddiqui took it. He unfolded it. He read it. What was on the card was not witnessed by anyone else in the building that night. Felix Okafor was at the central station with his back to the bench. Amar Nwosu was at the nursing station on the other side of the floor. Priya Desai was with a patient. Emmanuel Addo was in the family area. No one saw Siddiqui read the card. No one saw his expression when he read it. What could be observed by anyone who happened to glance down the corridor at the right moment was a change in Siddiqui's posture. Not dramatic, not sudden, a gradual shift in the way he was holding himself, the way a person's physical bearing adjusts when information recalibrates their understanding of a situation they thought they had already understood. He read the card for a long time, longer than a card that small should have required. Then he folded it once, carefully, along its original crease, and held it in both hands and looked at it for a moment longer. He set it on the bench between them. He did not give it back. He looked at Kareem. "How long have you been here?" he said. "At this hospital." 11 months, Kareem said. Siddiqui absorbed this. 11 months, he repeated, very quietly, in the tone of a man doing a private calculation whose result he does not fully know what to do with. He picked up the card. He placed it in his coat pocket. He stood. He looked down at Kareem on the bench, at this man in green scrubs with his hands on his knees and his gray notebook in his breast pocket, and 11 months of invisible, competent, underestimated work behind him, and a night like this one now added to whatever was already there. The suspension, Siddiqui said. It will not be discussed again. Kareem nodded once. Siddiqui looked at him for one more moment. There were things he wanted to ask. Many things. The card had opened a series of questions that a man of his experience and institutional knowledge understood immediately. Questions about background, about training, about what Kareem Yusuf was actually doing in Trauma Unit C of a mid-sized urban hospital on an 11-month nursing contract, and who knew he was there, and why. He did not ask any of them. Not because he didn't want the answers. Because he understood, looking at the man on the bench, that the answers were not his to receive in a corridor at 2 in the morning. They belonged to a different conversation, in a different context, conducted through the appropriate channels. And that Kareem Yusuf knew this as well as he did, and had handed him the card not as an explanation but as a direction. Follow this, the card said, in the language of institutions that communicate in exactly this way. Follow this, and you will understand what you need to understand through the correct process. Siddiqui was 63 years old. He knew how to follow a direction. He straightened his coat. Go home, he said. Get some rest. He walked toward the central station, where Felix Okafor looked up from his records with the uncertain expression of a junior nurse who is not sure whether to stand up when a director approaches at 2 in the morning. Siddiqui put a hand briefly on his shoulder. Good work tonight, he said. He walked toward Dr. Mehta. He walked toward Amaran Nwosu. He walked the floor the way a director walks a floor after a crisis, observing, acknowledging, taking the measure of what his people had been through. Behind him, on the corridor bench, Kareem picked up the gray notebook from his breast pocket. He opened it to the last written page. He looked at his notes from the protocol analysis meeting, the ones he had written while Harlan's revised triage chart was on the projector screen, the ones no one had asked about. He read them once, then he closed the notebook, and sat quietly in the settling corridor of a hospital that had held when it should have broken, and breathed. At 3:14 a.m., the emergency floor was quiet. Not empty. It would not be empty for many hours yet, perhaps not until the following evening, when the last of the 57 patients had been either discharged, transferred, or settled into ward beds with their injuries documented and their trajectories established. The monitors still beeped. The staff still moved. The work of a hospital does not end because the acute phase of a crisis has passed. It simply changes form, becomes slower and more deliberate, the sustained, careful attention that follows emergency the way a tide follows a storm. But the crisis itself was over. Kareem knew this the way he always knew when something was over. Not from an announcement or a signal, but from a change in the quality of the air, a shift in the acoustic texture of the building, the particular settling that occurs when a system stops fighting to hold itself together and simply holds. He stood up from the corridor bench. He rolled his shoulders once, slowly, the way a man rolls his shoulders when he has been carrying something for a long time and is now, carefully, putting it down. Then he went to work. The triage board first. He returned it to its standard configuration, erased the 3-category emergency system he had implemented at 11:40 p.m. and replaced it with the hospital's normal color-coded format, properly labeled, properly structured, reflecting the current status of all remaining patients with the same accuracy and the same clear handwriting it had carried all night. It took him 11 minutes. When he finished, the board looked the way it was supposed to look. Institutional. Standardized. Carrying no visible trace of the modified system that had managed 57 patients through the worst hours of the building's recent history. He set the marker back in its tray. The protocol note was next. He had been composing it in his mind since approximately 12:45 a.m., since the 3 simultaneous surgical crises had resolved and the floor had begun its descent from maximum pressure, in the quiet background of his thinking while the foreground managed what the foreground needed to manage. He sat at the documentation desk in the staff corridor, not the main nursing station, the smaller secondary desk used for quiet paperwork, and wrote it by hand on a single sheet of hospital notepaper. 1 page. No heading. No signature. It covered, in precise and practical language, the 6 protocol vulnerabilities he had identified and reported 6 days ago, updated now with specific observations from the night. Not theoretical projections of failure, but documented instances of exactly where, and how each vulnerability had manifested in real conditions. It included the field adaptations that had worked and why they had worked, written in language clear enough that any competent charge nurse could implement them without additional guidance. It included a recommendation for the secondary triage zone relocation, the most critical structural fix, with a specific suggested timeline and a note on the renovation corridor configuration that the protocol document had not yet accounted for. It did not include his name. It did not include the date. It did not include any language that could be read as accusation or vindication or anything other than what it was: a practical document produced by someone who had observed a system under real pressure and recorded what needed to change. He folded it once. He placed it on Amara Nwosu's station. Not prominently, not hidden, simply there, in the position where she would find it when she returned to the desk, the way useful things are left for people who will know what to do with them. He walked to the staff locker corridor. His access card had been deactivated with the suspension. The corridor itself, however, was not card-accessed after midnight. The door was on a manual push mechanism, a maintenance accommodation that had existed since the renovation. He pushed through it without difficulty. His locker was the fourth from the left. He opened it. It was mostly empty. The suspension letter had been accompanied by the collection of his personal items by the security staff member who had delivered it, placed in a bag that had been left at the front desk. He had collected the bag on his way out that day, without examining its contents. His extra jacket was gone. His personal coffee mug was gone. The medical journal with the broken spine was gone. What remained was a spare set of green scrubs on the top shelf. Not his personal property, hospital issue, left behind because they belonged to the building, and on the shelf below it, a single rubber band. He looked at the rubber band for a moment. He left it. He closed the locker. The walk to the emergency exit took him past Bay 6. Through the bay curtain, partially open, the way bay curtains are left when a patient is stable and sleeping and no acute intervention is in progress, he could see Nadia. She was asleep. Deeply, completely asleep. The way children sleep when they have been frightened beyond their capacity and have finally been permitted to rest. With her hands loose at her sides and her face entirely released from the tension it had carried when he first saw her, the small chest rising and falling with the easy rhythm of a body that is breathing without effort, without assistance now. The oxygen removed an hour ago when her levels had normalized and held. Her father was in the chair beside the gurney. He had been found at 1:20 a.m. in Bay 11, being treated for minor burns and a fractured wrist, awake and asking about his daughter in the unceasing way of a frightened parent who has been told repeatedly that she is stable and cannot fully believe it until he sees her himself. Emmanuel Addo had located him and arranged the reunion, which had occurred in Bay 6 at 1:35 a.m. and had been, by all accounts, a quiet thing. Not dramatic, not cinematic, simply a father sitting down beside his sleeping daughter and placing his unbandaged hand very gently near hers and not moving again. Kareem stood at the bay entrance for a moment. He looked at the child sleeping and the father beside her. Then he moved on. Priya Desai was at the medication station at the end of the corridor. She was updating a chart. She looked up when she heard his footsteps, and then she saw his jacket, which meant she understood that he was not starting something but ending it, not arriving but leaving. She looked at him. He looked at her. Neither of them spoke for a moment. Then she said, very quietly, "Will you come back?" He considered the question with the same seriousness he gave every question. "That's not mine to decide," he said. She nodded slowly. She understood this, not the specifics of it, not the full context, but the essential shape of it, that this man's presence in any particular place was not a simple personal choice, and that the card he had given Director Siddiqui had set something in motion that would determine what happened next through channels she was not part of and did not need to be part of. "The little girl," Priya said. "Nadia. She asked about you." Kareem was still for a moment. "What did you tell her? That you had other patients to take care of?" He looked at her. "That's accurate," he said. Something in Priya's face, something that had been held very carefully in place all night, shifted slightly. "Not much. Just enough. Take care of yourself," she said. He nodded once. He walked to the exit. The emergency door opened onto the staff parking area. The air outside was cool and very still. The particular stillness of a city at 3:30 a.m., when the last of the night has not yet become the beginning of the morning. when the streets are empty enough that you can hear the absence of sound as a presence in itself. Kareem stood outside the door for a moment. He put his hands in his jacket pockets. The gray notebook was there. He did not take it out. He walked to his car. The same car, parked in the same staff lot, the same route back through the barrier that the young security guard had waved him through 5 hours ago. The guard was still at the desk. Different shift, different guard. A woman this time, older, with the alert eyes of someone who takes the night hours seriously. She looked at him as he passed. He nodded. She nodded back. He got in his car. He sat for a moment in the dark and the quiet, with his hands on the wheel and the building behind him and the city around him and the night above him. And he breathed one long, slow breath, the kind of breath a person takes when something is finished and they are allowing themselves to know it. Then he started the car. He drove home at exactly the speed the roads permitted. The radio stayed off. In the morning, the floor staff of St. Aurelius General Hospital would learn that 57 patients from the Faro Road industrial fire had been received, triaged, treated, and successfully managed through the night. They would learn that 2 of those patients, a 51-year-old man named Osei Mensah and a 33-year-old woman named Saoirse Dempsey, had outcomes that the attending physician, in his quiet, careful way, described to the morning briefing as outcomes that required explanation. They would learn that the explanation involved a coordination structure that had been implemented during the crisis by personnel whose names were not fully clear in the documentation. They would learn that the triage board had been returned to standard configuration before the morning shift arrived, and that a protocol note had been found on the charge nurse's station, and signed, undated, 1 page, immediately actionable, that the chief medical officer would later describe, in a closed meeting with the board, as the most practically useful internal document the hospital had received in recent memory. They would not agree on who to credit. The man in the green scrubs would not be mentioned in the official incident report. His name appeared once, in a footnote to the suspension review, which was closed without finding and filed in a cabinet that very few people had access to. And on the charge nurse's station, beside the unsigned protocol note, there was one other thing that no one had noticed in the activity of the morning shift's arrival. A single rubber band, left on the desk the way certain people leave certain things. Not as a message, not as a symbol, simply as the unremarkable trace of a presence that had been there and was now elsewhere. Amara Nwosu picked it up when she arrived at 6 a.m. She looked at it for a moment. She put it in her pocket. She read the protocol note. She picked up the phone and called the chief medical officer. Some things she understood should not wait. The corridor was empty. The triage board was standard. The locker was closed. 57 people were alive. And somewhere in the city, in the early gray light of a morning that did not know what the night had cost, a man in a dark jacket drove home through quiet streets with a gray notebook in his breast pocket and said nothing to no one and asked for nothing from anyone. As he always had, as he always would. Black Medium Square End.